Let's talk about acute kidney injury. And I hate the term acute kidney injury because I was brought up talking about acute renal failure, but nowadays we can't talk about failure because it's such a bad thing to talk about failure. So we talk to our patients and say, you've got acute kidney injury, and they say, well, what does that mean? It means your kidney is failing you. Well, right, okay, fine, fantastic. And I think in terms of the management of patients with acute renal failure, there are lots of instances where care is less than ideal. And first thing I'm going to do is give you a single case history to prove that that may be the case. And of course what you do with a case history is you always find your worst case to present to everybody. And this is clearly nothing to do with anybody here, but this is a case that came across me about 5 years ago now. 70-year-old man, previously well, no significant past history, was referred up to the outpatient department of a district general in this area with a number of features, principally with joint pain. Widespread joint pain, and no immediately obvious reason why. Bit of swelling, bit of inflammation, and it was noted on that occasion that he had hematuria and proteinuria on urinalysis, and although it was said that his bloods were normal, his creatinine was at the upper end of the normal range. Now, in actual fact, if you use the sort of equations that allow you to calculate EGFR, that gives abnormal level of renal function. And he was started on some hydroxychloroquine, which would make his joint pains go away, and review was organised for 6 months. But unfortunately, 4 months later, on a weekend, he was admitted with hemoptysis. And of course, standard medical thought, hemoptysis, chest infection, pulmonary embolus, malignancy, something like that. But he also had weight loss, night sweats. Fair to say people were a little bit concerned. He had a chest x-ray performed which is diffusely abnormal, not one lump, but a lot of abnormal opacification of the parenchyma, and not in the sort of fashion that would suggest pulmonary edema. But his creatinine is 330. So people thought, and there's no obviously good reason for this. It's not as though he'd suddenly become shocked, hadn't started a new medicine, and people had a degree of concern. So he became unwell, more unwell over the next couple of days, further episodes of hemoptysis, and somebody said, this sounds to me like vasculitis. Not something we deal with in our hospital, but let's give him 3 massive doses of steroids. And over the weekend, his creatinine rose to 400. And on the Monday ward round, it was said, I think we should run this by the renal team. Tell you what, Paddy's in tomorrow. Let's wait until tomorrow, and we'll just write out a notice and stick it on his desk. And I arrived on Tuesday morning, I read this notice, I rang the ward and said, I'm not seeing this man, he needs to go straight through to the Royal. He did on the Tuesday AM when he had a biopsy done that confirmed an acute vasculitis. He started the definitive treatment, but was in ITU 4 days later and died of respiratory failure from multiple episodes of hemoptysis 6 days after that. And I think there are a number of points in his management which could have been done better, and which I will keep on coming back to over the next 37.5 minutes. Where could that have been done better? It could have been done better in the initial clinic visit by getting the bloody diagnosis right first. Sorry about the film, man. And okay, this in actual fact was an acute vagus granulomatosis. I don't expect anyone here to necessarily know the ins and outs of vagus granulomatosis or even vasculitis. But the important points were recognition of adverse clinical signs in the clinic. Not only did he have joint disease, but he had signs of kidney damage already with slightly abnormal bloods and blood and protein in his urine. Second, when he comes in, people obviously recognise that the man was sick, but I do believe that the action was slow, and more importantly, over a 3-day period is knowing your limitations. And in this instance, allowing a 3-day gap until the specialist comes along, I think was causative in this man's demise, as were all the other bits. Clearly things that you would never do, only the sort of things that medical staff would do. And, as I say, these are just some of the areas to discuss. But, don't just go by my single case history. There's better evidence than this, that our care of patients with acute kidney injury, acute renal failure is not that good. And this is where we come to my title. Because adding insult to injury is the title of a document produced by this bunch down here, UNCPOD. If you're going to come up with an acronym for an organisation, make it one that you can actually say. So, UNCPOD is the National Confidential Inquiry into Patient Outcome and Death. I'm sure they could have come up with something a bit better than that. And the National Confidential Inquiry into UNCPOD started out as CPOD. They were probably okay with CPOD. I guess they managed their talks quite easily with that. And they started off in 1982 just looking into perioperative death. And as time went by, they sort of got bored with that because they realised there was lots of it and they couldn't influence it, I suspect. And then they started looking into some other things as well. And NCPOD Mark II has looked into all sorts of various things over the years, some of which are shown here. And they always come up with some snappy, vaguely humorous title for their reports. I can't remember any of these, like Surgery in Children, God, Aren't They Ugly, or something like that. I can't remember. But for this one, because of acute kidney injury, it's adding insult to injury, whatever. And what they did is they thought, the usual thing, sitting around a desk, okay, we've done children's surgery, we've done all these other things, what else can we do? Oh, I know what, acute renal failure, can't call it that, acute kidney injury. There's quite a bit of it around. Although no definitive studies have been undertaken in the UK, the prevalence amongst hospitalised patients in the US is about 4.9%. 1 in 20 patients have got acute kidney injury, and I suspect even that's an underestimate. Associated mortality rates have been wide-ranging but awful, generally speaking. And clinically, and these are the important points, acute kidney injury should be easily recognised by the onset of oliguria, anuria, passing little or passing no urine, and that should be fairly easy to detect. Or deteriorating biochemistry, ditto. However, if unrecognised and allowed to deteriorate, acute kidney injury will result in uremia, acidosis, hyperkalemia, and death. And these are the important parts. And what CPOD did is they looked at it's something just over 500 patients, adult patients, admitted into hospital, who have died over a 3-month period in 2007, where acute renal failure was at least part of that death process. Patients on dialysis are excluded, patients admitted for palliation are excluded. So these are largely patients coming in with general medical problems. And they went through the notes and they disseminated them amongst a large board of people who reviewed them. And there were renal specialists, there were intensivists, there were orthotists, a multidisciplinary group. And then they gave their opinion on a wide array of features of their case, diagnosis, management, and so on and so on. And you see from this, the vast majority have come in through the general medical units, care of the elderly, a small number tailing off towards the end. The fact that there's so little acute renal failure in orthopaedics makes me think they just failed to notice it rather than anything else. Death caused by nail driven through bone, I suspect. But anyway, moving swiftly onwards. And not too surprisingly, it's an elderly population, which is moderately important. And here's the first and most important feature. The red line that I have drawn here is the 50% group. It's the 50% level. Just over 50% of patients with acute kidney injury have good practice. And the others have a variety of things. Room for improvement in clinical. They divide things into clinical and organisational. Organisational is, do you have the facilities in your department to do nephrostomies or ultrasounds or biopsies or whatever. And I don't particularly want to get bogged down in that, but let's just look at the clinical. There's a substantial number of people here, 25-30% of people, in whom there's room for improvement on a clinical basis, and there are let's say about 10 or 15% down here, in whom the care was thought to be less than satisfactory. Okay, it may not be much to have 10 to 15% of that, but I think we would all strive to have our patients in this block here. And the fact that this is only just over 50%, I think it's rather worrying. And that was the conclusion. That was the conclusion of the whole talk. End of talk. Right, so in terms of getting the diagnosis right, I mean, any idiot, other than the orthopaedic surgeons, can spot acute renal failure. There's oliguria or anuria, and if you are keeping some eye of fluid balance, then you should be able to spot that. There are abnormal U&Es, and nowadays you don't even need to have me to say, look, that creatinine 112 was abnormal. You've got bloody you've got EGFR that allows you to sort of say, yes, this is markedly abnormal renal function. So I'm not too worried in spotting it. It's asking the questions that then follow on. The main question is, why has this happened? And the list, okay, the textbook list, and this is one of the problems, is we have our junior doctors, they get out their little yellow Oxford Handbook of Medicine, and the list of causes of acute renal failure is, of course, this long. And it includes things like acute vagus granulomatosis. So halfway down they go, oh my God, acute vagus granulomatosis, what am I going to do about that? 75% of all acute renal failure is related to volume depletion, or call it dehydration, I don't care what you call it, but it's fluid lack. And yet we do tend to concentrate on these medical minutiae. Thereafter, or in conjunction, medication. And medication in two forms. Either the sort of chronic medication that people take for their heart failure, their hypertension, their diabetes, which, in conjunction with volume depletion, and the next one, contribute to acute renal failure, or the sort of people who've recently been given a new medicine and have had a reaction to it. But medication is a huge part of acute renal failure, and I always teach our lot that if you've taken a thorough drug history and you haven't found a medicine that has in some way contributed to this, then you have failed to take a drug history, because it's almost universal. Sepsis. I know sepsis is a major feature of everything that we do, but again, I regard it as being a universal accompaniment to acute renal failure in our patients. It has either been there at the onset in the community and has sparked this process off, and if it doesn't happen there, it happens in a few days down the line when we've done what we do to our patients. Ventolins in that become cellulitic, central lines in that become infected, catheters that become infected. Desperately important. And again, in conjunction with medication, which I'll come back to later, this is a recipe for disaster. 10% of acute renal failure is caused by obstruction of urinary flow, bladder, prostate, ureters, something like that. Quite a bit of acute renal failure is caused by other non-renal disease. So again, the patient's heart failure, their diabetes, their pneumonias, GI bleeds, and so forth. And the sort of things that feature in this huge long list of causes of acute renal failure, which are the primary renal diseases, make up a tiny amount of what presents. And for most people, their acute renal failure is just part of being extremely unwell, not a primary renal disease. Now, patient comes into hospital. Can we predict who's going to develop acute renal failure? Clearly, some are coming through the door with abnormal electrolytes, but there are some who come in with mild abnormalities. Can we spot those who are going to suffer? Yes. They tend to be the elderly. And they tend to be the elderly because the elderly already have several things. Other comorbid diseases, diabetes, hypertension, heart failure. They're on their medication. They've probably already got chronic renal impairment. And they don't respond very well to hypovolemia and so on and so on. So all of these features tell us who's going to develop acute renal failure or who's going to have a bad outcome in our hospital population. And CPOD noted from these 500 or so patients that there was inadequate assessment of these risk factors. And again, it's just rather sobering to have a look down at some of these and see. I accept that I think we are not taught very well how to do nutritional status. It is difficult to check the weight of somebody who's systemically unwell. I'm not entirely sure how you make an inadequate assessment of age. That's rather an interesting one. I have no idea. But inadequate drug history, inadequate assessment of volume status and a failure to appreciate someone's volume status, sepsis. I mean, I think these three are fundamentally important, and I'll come back to some of these other ones here. So we're not very good at actually assessing our patients and identifying who's in trouble, despite the fact that we have amazing colour-coordinated charts that tell us who's going to be in trouble. I personally have found it a slight shame that we've had to have these, because what it implies to me is that we failed to look at these charts in the days that they weren't colour-coordinated and we couldn't interpret them properly. So we've had to have colour coordination, and at the end of the day, some of you will actually notice that the sums aren't added up properly down there anyway. Sorry. Moving swiftly onwards. I think one of the problems here is that for some of us, when we were young, which is quite some time ago, when we were called to see people who'd just come in through the door or they had acute ill health, we had a bit of time to make a thorough assessment. We had a time to go through their records and all of their variables. We had time to think, and we had time to start treatment and take time to monitor its effect. Whereas nowadays, I have to say, for the people who are target patients in nowadays, the first thing they've got to think about is when do I discharge the patient and when am I going to get to bed and so on and so on. And I think there is an issue here with quality of care. Could there be an issue with the grade of doctor who sees the patient as they come through the door? Well, let's just start off with